Muslims. Looking forward to this as we have some of our guests joining us right now. We're going to be recording this call just so everybody knows. And inshallah, in the next like 45 minutes to an hour, we'll have the opportunity to hear from some of our incredible Muslim physicians that are a couple years ahead of us, get some advice, ask a few questions. Before we get started, just as always, we're just going to start with Surah Al-Fatiha. If everybody can just in their hearts or out loud, just read Surah Al-Fatiha to themselves. Bismillah. So the over the month of June, we were having 4 of these panels. Last week we had an internal medicine panel. Alhamdulillah, we had a pretty good turnout. And it's nice seeing people jumping into this call today, which is a surgery panel. We initially had a pretty comprehensive list of people coming to speak. We just got a few emails that people are still in the OR and seeing patients. So we're limited to 3 of our speakers. But mashallah, they're here and happy to introduce them to you guys. So I'm going to hand over the floor to Oais, who's going to kind of guide the evening for today. So.
Assalamu alaikum warahmatullahi wabarakatuh. Jazakumullah khairan, Basil. Appreciate everything that you do. My name is Oais. I'm a part of the AMMSA national team. Really excited to hopefully lead the conversation tonight, gain some insights into some of the different surgical subspecialties. And without further ado, inshallah, I think you can introduce our 3 panelists that we have right now. We have Dr. Shadi Mehrab, we have Dr. Sahil Saleh, and we have Dr. Gulrez Mahmood. So I think maybe it would be helpful, Dr. Mehrab, Dr. Mahmood, Dr. Saleh, if you could talk a little bit about your respective specialties and maybe where you are right now so that everyone has an idea of sort of where you're coming from. Yeah. Dr. Mahmood, feel free to go ahead and show.
Am I muted? Can you hear me?
Yep, we can hear you.
Oh, okay. Assalamu alaikum. My name is Gulrez Mahmood. I live in Baton Rouge, Louisiana. I'm a vascular surgeon here. I grew up in Michigan. I'm from Pakistan originally. I went to medical school in Detroit at Wayne State, and I did my general surgery training at Western Michigan in Kalamazoo. And I did my vascular fellowship at Vanderbilt in Nashville, Tennessee. And I'm about 1 year out of training. And I got an invitation to come to this talk, and I'm delighted to be here. Thank you for inviting me.
We appreciate you coming. We appreciate you making the time, especially now schedules can be really hectic. Dr. Mehrab, please feel free to introduce yourself.
Hey everyone, I'm Shadi. I'm one of the ENT residents at Michigan. I'm a PGY2, going into my 3rd year of residency. I really didn't think about surgery at all when I was in medical school, like entering medical school. So I'm really happy to have kind of discovered it, and I really love it. So I'm definitely here to answer any questions, especially if you never really thought of yourself as a surgeon or really entertained that career path. I think it's amazing.
Awesome. And last but not least, we saved the best for last, Dr. Saleh.
Definitely not the best, but I appreciate the thought. I'm Sahil. I'm a PGY2 in ophthalmology, actually, and I'm at Beaumont Hospital in Royal Oak. I did med school at University of Michigan, and so I'm pretty local to the area. So if you have any questions about ophthalmology or anything residency related, really, feel free.
Phenomenal. Thank you so much. And I think because we have a pretty manageable number of students, we won't be doing the breakout rooms. I think we can just have a discussion. If students have any questions, we can sort of just do that and have the panelists jumps in. So yeah, if anyone does have any pressing questions, you can feel free to drop them in the chat or unmute yourself and ask. If not, I have a list of questions you can sort of go through in terms of like introductory, like what got you interested in your specialty and things like that. So if anyone does have any questions, feel free to speak up now. If not, we can go down some other questions I have, inshallah. Okay, yeah, no problem. So as I'm sure you'll have some questions come along during the call. So I think one common question that a lot of medical students have is, how did you sort of make that determination that you're interested in a procedural specialty versus something like medicine? And what sort of guided your interest towards surgery? Anyone feel free to jump in.
Well, I went to med school with the thought that I should go into surgery. I've always wanted to work with my hands. And then I think you kind of get a sense early on as a medical student whether you enjoy the puzzle solving, clinical aspect of medicine, or if you like, the immediate result and impact of surgery. I think, and the other thing is you have to have some grit. If you're dealing with people in the OR, there's just different personalities, so you have to be able to deal with those personalities in surgery. And I think a lot of students tend to shy away from it. So I'm here to tell you that that's no longer the case. I think if you are interested in a surgical specialty, you don't have to be worried about that anymore. I think people are a lot more friendlier, and staff is much nicer than they used to be back in the 90s and early 2000s. And in terms of why I wanted to do vascular, I didn't really have any inkling of interest in vascular surgery. I just went into general surgery with an open mind, and I had some good mentors. And in vascular surgery, you get to operate all over the body. There's small procedures, there's big procedures. There's a lot of variety day to day. You can work on something simple like a venous procedure, or something complex like an aortic, operation. And I like the immediacy of the results, and the patients are very grateful and very, very. It's just a very satisfying specialty, I think.
Absolutely, we appreciate the clarification, Dr. Mahmood, and definitely the journey on the way to vascular surgery is something we appreciate. Shadi Sahil, do you have any thoughts, maybe sort of how you sort of made the determination in medical school with ENT and ophthalmology? What your thoughts were? Maybe it was the anatomy, maybe it was the types of procedures. What sort of attracted you towards the fields that you're in?
I would say for me, the first kind of revelation was just that I really liked being in the operating room. It was not a setting I imagined I would have loved so much, but I just found that I was happier on my surgical rotations because I was up on my feet, I was more active, I was problem solving as I went, and that was a workflow that worked better for me than kind of floor work or clinic. So the first thing for me was the setting. The second thing for me was the anatomy and kind of the surgical subspecialty that I ended up in. I saw a neck dissection and I thought it was absolutely the most beautiful thing ever. And that was really exciting for me. And then the third thing for me was mentors. Really, I had really good mentors, and I think a lot of people end up in certain specialties because they had influential people in their lives who guided them there. So it's fortunate and unfortunate that you could miss something that would be good for you, or you could end up in somewhere you didn't expect if somebody takes you under their wing. So, and then conversely, if you see somebody who you really don't like, maybe you don't want to go into their field because you think everybody in that field is like that, and that's certainly not true. So definitely I think keeping an open mind is how I got here.
I'd also echo a lot of what Shadi said in terms of like the setting. For ophthalmology, it's much more clinic based than it is OR based, but even in the clinic, you're still able to do a lot of hands-on procedures. The physical exam, the slit lamp is a very technical skill. Using like the different lenses and stuff is, you're always using your hands, and that's something that I really appreciated. And it's very kind of like tech heavy. And I've always kind of nerded out about that stuff. And I just felt like, long term, there's always long-term developments of like new tech that's kind of introduced into the field, and it's very innovative. And so I really appreciated that aspect of it. I mentioned, there's like a clinic to OR split. Sometimes like some surgical subspecialties are very OR heavy, where you're in the OR like, 3+ days a week. Ophthalmology, I would say, is unique in that, honestly, like if you do like 1 or 2 days a week in the OR, then that's kind of like a busier OR schedule. And I kind of like that breakdown because, you're in the OR and you still get enough OR experience, but you're also in clinic. And again, in clinic, you're still doing a ton of different procedures in and around the eye that helps, people see or decrease pain or whatever the case may be. With ophthalmology more specifically, obviously you have to be comfortable using kind of a microscope, whether it's the slit lamp in clinic, that's going to be like your bread and butter. And then when we're operating, unless you do something like oculoplastics, most of the time you're going to be at a microscope as well. So that's just something that I like to put in people's minds who are considering ophthalmology, because that is what you'll be doing kind of day to day.
Thank you so much. I think that was really helpful for everyone that just came in. Alhamdulillah, we're joined by 3 panelists today, Dr. Mahmoud, Dr. Mehrab, and Dr. Saleh. Dr. Mahmoud is from vascular surgery, Shadi Mehrab is from ENT, and Sahil Saleh is from ophthalmology. So if anyone has any questions at any time, feel free to just raise your hand, post something in the chat. Alhamdulillah, we have a couple of sort of general questions we're kind of running through right now, just to get an idea of the journey that our panelists had to enter into their surgical subspecialties. But the more we can turn this and facilitate this into a conversation, and the more we can cater to your needs, we're happy to do that. So please don't hesitate to put something in the chat or unmute yourself, whatever you're comfortable with. With that being said, I think a common thread that we noticed through each of your sort of 3 responses was the importance of mentorship. And I think something medical students are always in the process of trying to do is identifying good mentors and building strong mentorship connections. So I was wondering if any of you had any thoughts or recommendations or advice on sort of how to identify good mentors and how to facilitate that relationship in the future.
Well, I think you have to show some interest first in order to identify who's willing to go out of their way and teach you. As a medical student, that means being on your surgery rotation. You got to be prepared for whatever procedure you're watching, and knowing details about the patient, and just being available to help. I think the key is for a medical student to just be present. I think if you show that interest, you'll be able to identify people that are willing to set aside time and teach you, both among residents as well as faculty. And besides that, if you already have an interest in developing, or you think you might be interested in a certain subspecialty, you can seek out mentors or do some sort of research project or get involved in some of the research that's available in especially if you're at an academic institution. And I think that's the best way to go about it, is just be present and show interest.
Shadi, please go ahead. I was just about to ask if you had anything to add.
I was also going to say, I mean, obviously, like, this is a mentorship panel that we're doing today, and it's honestly a really great opportunity just to kind of see who's out there, but also to just kind of set the stage. And it's kind of up to you at that point to either follow up with whichever person you either connect with, or more importantly, trying to do the same, but in whatever community that you're in. So during med school, we had like a brothers halaqa that was filled with a lot of like upperclassmen, and super thankful for that, because a lot of them, or like a few of them, were actually had matched ophthalmology, and it was like one of the first exposures that I got. And you got those opportunities to kind of ask whatever questions that you had. You can pick people's brains, and it doesn't have to be you don't necessarily need to commit to whatever the mentor's specialty is, right? Like, they can offer you a lot of help or guidance, just trying to pick at their brain. And I think part of like being a good mentee, though, is that you kind of have to do some of that own work on your own time, whether it's like really diving into the specifics of a specialty and knowing what the day-to-day entails, or asking the right questions, or just showing some sort of interest overall. So kind of a two-way street in that respect.
I totally agree. It's definitely a two-way street. And I feel like, when I was in medical school, I wasn't shy about asking people for meetings if I felt like I could also engage in a good mentor-mentee relationship. But I was also, conscientious of not engaging too much in something that I didn't think I could follow up on. So for example, like committing to a research project and not following through on it, or reaching out to get coffee with somebody and then not following through on figuring out a date, things like that. I don't think anyone intentionally does those things, but I feel like they do kind of leave an impact sometimes that you don't intend to. So you can be thoughtful about it, but also not shy to kind of ask for meetings if you admire somebody or you look up to them, whatever it may be. One piece of advice I got for during my medical school surgical rotation was to be available, affable, and able. And the least important one was being able. So for sure, if you can just show up in the OR and have a good attitude and be ready to learn and not demonstrate arrogance or, lack of preparation, that goes a long way. I feel like when I say these things, people are like, duh, like who would do those things? But you'd be surprised. So if you can kind of demonstrate those things, that goes a long way.
Absolutely. I think that makes a lot of sense, especially because in medical school, of course, the schedule seems rigorous and there's so much to do. You have to go in for rotation study afterwards, but then even I'm sure that as a resident and as an attending, it just becomes busier and busier. So we also got a question from the audience about if you had any advice for Ramadan and how you sort of balanced Islam as a medical student, as a resident, and especially Dr. Mahmoud, I think you might have some insight now as an attending. You've been through the entire journey, so really curious to hear how all of you sort of manage that kind of balance of there's the career, there's medicine, there's surgery, but there's also that component of Islam, and how do you sort of combine the two?
Well, I think your schedule as an attending is a lot more controlled and a little bit more predictable, and it also depends a little bit on your practice setting. But for the most part, your hours are going to be probably better than they are as a medical student and even as a resident. And so I don't think it matters as much. I think during fellowship, especially, the hours are pretty brutal. It really helps to have a sense of community and being able to do iftar and have Friday prayer with other colleagues is very, very, it's a blessing. So if you're in a community that has even a couple of Muslim medical students, consider yourself very lucky and try to stick with them, particularly if they're in your own cohort. So if you're in like a surgical rotation together, it would be very helpful to just kind of tag team with them.
Shadi, Saho, any thoughts? I know you've also been.
I mean, obviously, as residents, like Dr. Mahmoud was saying, it's really difficult because you have almost no control of your schedule. With that said, you do have, minimal control. So the way that I try to do it is at least like if I could take either like reach out in advance to see if it was a possibility to get a quote unquote like lighter rotation during the month of Ramadan, or at least a portion of Ramadan. And then if possible to also schedule like a vacation or some vacation time, like days during it. Obviously it's not always a possibility, and oftentimes, it doesn't work out. But like honestly, subhanAllah, like you end up getting through it. You do the best that you can. Obviously, like when you're on a busy, surgical month or you have like a heavy call burden, whatever the case may be, like you may not do as much going to the masjid or, reading Quran or whatever the case may be that you'd want to. But honestly, it's a matter of kind of adjusting expectations, knowing that, in the long term, inshallah, like you'll have a little more control over your schedule, and that it's kind of a finite amount of time that you try to make the most of it while you're a resident. I remember, I don't know if any of you guys are from U of M, but Dr. Aleem, he's like an ortho attending there, but we had like Taraweeh on campus, and he was the one leading Taraweeh. And I know this dude had like cases scheduled like 5-6 hours after we would finish. So he like set the bar really high, but I kind of reminded myself, like, you don't necessarily need to be at that level right now. You can always kind of work to it or just do what you can, and something is better than nothing.
Inshallah. And I think with also just being in the field of medicine itself is a blessing, because our day job is tied to the hadith and the the Sunnah of Prophet Muhammad sallallahu alaihi wasallam, just being able to alleviate the difficulties of others, and even if it's working long hours and it might not seem as directly related to Islam, it is in a sense if you can rectify the intention. So even just the process and the motions, of course, it's difficult. Of course, it's a job, but it's also a huge blessing to be able to contribute in that respect. I think another question that some students have is kind of that dynamic of course, residency is really tough in pretty much all surgical subspecialties. How is the life as an attending, and how much should that kind of component of course, residency is hard, but then attending life is more controllable? How should that sort of dynamic play out? What are your advice and thoughts on that?
It really depends on what kind of practice you're looking for. If you're interested, whether you're interested in going into private practice or an academic setting, they're very, very different. And I would say most of the employment opportunities nowadays are hospital employee based. So you're going to be a salaried employee, and you may have an RVU incentive built into it, versus going into private practice, which is kind of like the Wild West. There's not really any singular model for private practice. There's very many different, payment methods and partnership tracks and things like that. You really have to find mentors in the community that are in those different practice settings, work with them, see what their day-to-day life is and what their routine is, to understand what the difference is and what you would like and what you see yourself doing, 5 to 10 years from residency. And you can always switch back and forth. A lot of people say that it's more difficult to switch back into academics from private practice, but I've seen it happen. I've seen people do it either way. You can start off in academics and switch into private practice, or vice versa. And trying to think what else. You really want to have different mentors and different experiences. It's tough to get experience in private practice as a resident because most of its training programs are going to be in academic centers. But I think most residencies have some sort of built-in away rotation where you can do like an elective, and you can find a group that's nearby, your hospital, or even somewhere near your hometown. You can go and practice with them for a little while and see what their day-to-day routine is like. But I think overall life is, much better after training. Obviously, you're at the helm and you make all the decisions. Starting off, I'm in my first year of practice. It's definitely the responsibility is much greater. The stress is a lot higher, but there's also more reward when things go right, when you make the right decision. The other important thing to keep in mind is if you're starting off going into practice after residency, you want to have good partners, partners that are available to help you, partners that you can trust. And it's very important to have that when you first start off and find your first job, because you want to have good outcomes, and you want to be able to run through cases with seniors that have more experience than you. The last thing you want to be in is a situation where you're a fresh graduate and your two colleagues are also fresh graduates, because that's not an uncommon situation to be in. But you got to keep in mind that you're not going to be doing very complicated cases unless you have some senior mentorship available and ready to help you if things go south.
Thank you, Dr. Mahmoud. That insight is very helpful as well, especially knowing that there is sort of a light at the end of the tunnel in terms of the attending hours finally getting a little bit more controllable, and that kind of scope of practice finally coming into play. So we've had a lot of people moving in and out, alhamdulillah. So just to kind of reset the room, alhamdulillah, everyone, we're joined by 3 panelists today, Dr. Mahmoud, Shadi Mahrab, and Sahil Saleh. So Dr. Mahmoud is a vascular surgeon, Shadi is an ENT resident, and Sahil is an ophtho resident. And if anyone has any questions at any point in time, feel free to message me or put in the chat any questions that you have. Though we're just sort of going down the classic list of why surgery, how did you find your specialty, and mentorship, things like that. With that being said, I think another question that is on the mind of several students, especially maybe in their M1 or M2 or even M3 years, what are the best ways to explore different surgical subspecialties if someone's still undecided?
the best way to do it is during your surgery rotation, you're going to have a lot of opportunities to see all the different types of operations. Again, just like we alluded to earlier in the talk, just being present and available will give you, more responsibility in the OR. If we see that a medical student is interested and they're trying to gain competence, we'll give them gradually more and more responsibility. And besides that, any time that you have some time off, or if you have an away elective that's built into your medical school curriculum, try and shadow somebody. Go and arrange a mentorship for 1 or 2 months where you can go and rotate with a surgeon. A lot of times what medical students used to do when I was in Detroit was they would go out into the country in the rural setting and work with like a general surgeon, and they would get to be first assist and really get a good experience of what it's like being like a true general surgeon. So if you have any inkling of interest, you should go and kind of find Muslims that are out in the community that would be willing to take you under their wing, because it's really not an uncommon thing to do. I have college students come and shadow me in the OR. They come and spend a day with me in the clinic, and you just find people that are ready and available to do that for you.
Shadi Sahil, I know that you are also sort of early on in residency as well. So maybe you have some interesting insights in how you sort of chose, for example, your specific like ENT or ophthalmology as compared to like if any other specialties were on your mind, and how that dynamic sort of played out.
I was just very inquisitive and curious as a medical student. So anytime my patients, even when I was on medicine, like had some procedure that they had to go to, I would go with them just to watch. So my patient on medicine had to get a bronch. I went to the Palm Suite. I had a patient who needed their, they had really bad AFib. They had to get ablated. I went down to the EP suite. So you can just find kind of opportunities across your rotation. For sure, if you're just open-minded and curious. And then also if you have downtime on more, relaxed rotations, obviously you want to make your priority that learning. But I remember on my psychiatry rotation, I would finish the day pretty early and then I would head to the ENT ORs. And I didn't even know this, but people notice that kind of thing because they know you're putting in extra work too. So it was kind of a win-win. I got to see more cases and figure out if I liked it. And then also people thought it was, demonstrating dedication.
I ran straight home after my psych half days. It worked out for me. But I at U of M we had like lunch seminars where they would bring like different specialties, where just like over lunch they'll bring a resident and attending where they kind of talked about their like day to day. I thought that was like very low, like kind of like really easy, low effort kind of thing, just to get exposure like really early on. I think something that in retrospect I wish I would have done was there's a lot of opportunities to shadow or to just jump in different clinics earlier on as like an M1, even in like the preclinical space. But I always had this feeling that it's like, oh, like, am I actually interested in this? Or for whatever reason, I just hesitated to actually like commit to even like a shadowing session, which is like pretty low key. Or there was like other opportunities where you can kind of join. I think they have like optho like programs, or it was like mentorship kind of thing where, again, I just kind of convinced myself that I wasn't like as interested. I would say like you don't need to commit as an M1 or M2. So even if you show up to these things, it's not a binding contract. They're not going to like be disappointed in you if you end up changing your mind. People do it all the time. And if anything, like it will be a good way just to kind of show face. And if you do decide to pursue that specific specialty, then you can kind of start to build those relationships really early on. But again, those things take extra effort, like Shadi had mentioned, right? Like you have to kind of go out of your way, whether it's, you're in preclinical, you have all this new information that you're learning, but you still have to kind of be mindful that that once your clinical rotations and core rotations end, like M3 rolls around and ends real quick, and then you're applying to residency. So having that in the back of your mind is a good thing just to think about long term.
Absolutely. We have some questions coming in from the chat as well. So Hassan's asking, how did you realize that you enjoyed spending time in the OR? And did you know that it was something you liked from the first time you went in? So it was kind of a moment of clarity. It's like a movie, you walk in, you know you're going to be a surgeon. Or was it sort of a gradual, you realize over time, oh, this is something I think I see myself doing the rest of my life?
It was a little bit of both. You know, being a surgeon, that's what I wanted to do when I went to medical school. But I remember very vividly the first operation I saw was a cervical cerclage. It was a OBGYN, and it was just disgusting, and I almost passed out, but because I could smell the cautery, and it was the first time that I'd smelled like burnt tissue. But it's something that I gradually kept pushing, kept going to see different procedures. And the other thing was, when I was a medical student, personalities were still a little bit prickly in the OR, and it was just something that you had to be prepared for. And there's just this certain pace in the OR, and if you're able to keep up with it, you're going to be appreciated, and you're going to be able to get more out of the operation. So again, it goes back to being present, being on top of things, being prepared as a medical student. It's just the typical things that you want to be as a medical student. But it wasn't like it's not like the movies. I mean, it's an OR. There's different procedures. There's different settings. You're going to be in the cath lab. You're going to be in, like Shadi mentioned, like if you've seen a bronch, that's sometimes done in the patient's bedside, in the room. So there's different settings, and you have to just keep showing up, keep pushing yourself, and keep testing yourself to see if that's something that you can see yourself doing over the next, 30 years of your life. And I'll be honest, it's not for everybody. Some people just prefer office work. They prefer sitting in front of a desk, reviewing labs, and doing like clinic encounters all day. And I think that you'll be able to tell whether you're one of those people or not.
Dr. Mumu, I'm just curious, what's your clinic to OR split?
I have clinic one day, and the rest of the days I'm doing OR. And even on my clinic day, I try to sneak into the OR, try to get a quick cath lab procedure in before or after.
ABCs, huh? Anything but clinic.
That's right.
I think so. For me, I enjoyed the OR. With that said, ophthalmology OR is like a completely different like vibe compared to like a gen surg OR, like an ENT OR. Like first thing you do is you go and you like pull up a stool, you sit at a microscope. It's the best thing ever. You don't need to stand for 8-10 hours. And then again, you're at a microscope, which is a very different it's a very different like set of skills that you need to be comfortable with and that you build over a long term. And it kind of presents its own unique challenges. And the only way that I've like ever described it to people is if you literally like look through a microscope, like you have to set like your pupillary distance and stuff and be comfortable with those like micro movements. With that said, like I would recommend at least popping into like an ophthalmology OR just to get a vibe for things, because it's very different. Like I know people who are doing ophthalmology but hated like their regular gen surg rotation, for example, and it is pretty different. And then, yeah, I lost my train of thought. So we'll keep it at that.
I will say, I feel like you have to love the OR. Like you have to love doing procedures and doing things with your hands to make the training worth it, because you do spend a lot of time in the hospital no matter what you go into. For sure, if you do something procedural, you will spend more time in the hospital because there's just a lot of downtime, patient has to wake up, whatever, all these things. You will spend, I would say, about 30% at least more time in the hospital than your medical counterparts, and that has to be worth it. To me, I was like, okay, it's 30% more hours, but it's 200% more fun. By math, then it works out. And that calculation makes sense to me. So for me, I just thought it was really fun. As I become more and more, responsible for the actual outcome, the fear and the fun balance are, shifting. But at the core of it, I just think it's really fun to work with my hands, and I can't imagine a field where I don't do that. also within ENT at least, there are so many different types of procedures and skills required that I think anybody who wants to be in the OR would find something they love within my field. And I'm certainly discovering that I love so many different aspects of it because we have endoscopic work, we have, working with really, really tiny things under a microscope, working with the ossicles, the hearing bones. You have big cases, you do big free flaps, you take muscle from the leg and you put it in the face. We do really cool things. And I think that also keeps me really interested.
Phenomenal. Jazakallah khairan, everyone. And we have a couple of questions coming in that looks like the audience woke up. I think this needs a little conversation to get their thoughts going. We have a question from someone that there's several medical students now that are maybe like alternate careers or took a couple of gap years. So like maybe late 20s, early 30s and applying to residency. So the question is, like people keep hearing that surgery consumes your life. So is this necessarily true, or can you kind of strike a work-life balance, especially for medical students that are a little bit older or at a later age?
Well, the way you look at training is that you have a set time period to get through training, and you have to see as many cases, and really you have to see as many complications as possible because you want to know how to deal with them when you get out of training and when you're on your own. And that it's really a matter of how many cases can you fit in your training under the duty hour limit. I will tell you that as a general surgery resident, the duty hour limit didn't really apply to me. I'd rather just be in the hospital and do cases. So it does take a toll on family life, depending on which specialty you go into. I mean, some specialties are a little bit more family friendly, I would say. But once you get out into practice, you have to always keep in mind that training is training. But once you get out into practice, you have full control over your schedule. If you want to have a busy lifestyle, that just means that that's the kind of setting that you're going to, find and look for. If you want a more laid back situation, then that's what you're going to do. Even in vascular surgery, which is supposed to be a very busy long hour specialty, you can find a practice that does mostly venous work, and you can be home at 2 in the afternoon. You can limit your OR days. You can have more clinic. You can do more clinic-based procedures like saphenous vein ablations and things like that. So you shouldn't limit your options based on what it's going to be like at the end of the road, because you really have a great degree of control over your schedule once you get out of training. But during training, I would say if you're going into a surgical subspecialty or a surgical specialty, you should be prepared to spend long hours in the OR and in the hospital.
Okay. Another question, Dr. Mahmoud, I think that was really helpful, it was really insightful again. And another question we have is sort of kind of contrasting maybe the surgical specialties with anesthesiology. So of course, both are in the OR, but perhaps anesthesia, of course, the roles are very different. And maybe the thought is that anesthesia, they still have some involvement in the OR, but the hours might be a little bit easier, even in residency and definitely almost outside of residency. Do you have any advice to students considering that sort of dynamic, interested in the OR, but maybe not as a surgeon, as an anesthesiologist?
I think the similarity ends with the fact that you're both in the OR at the same time. That's really it. Even in anesthesia, there's a lot of different branches now. You can go into pain management, you can go into, procedural subspecialties, you can go into pediatrics, you're going to know whether, and you should really see, rotate with anesthesia and see what that life is like. It's very different. I would say the pace is different. The responsibility is a little bit different. Definitely there's more control over your schedule. The hours are going to be more predictable and all of that. But, I can't really comment on what it's like as an attending in anesthesia because I haven't done that. I don't really know what life is like there. But I have friends and they seem very happy and they've all made the right decision to them. They've done fellowships in different subspecialties of anesthesia and they're very happy. But for me, I wanted to be on the other side of the curtain. I wanted to be the one responsible, and I wanted to see what happens after we take care of the patient. I wanted to see what's the outcome, and I couldn't do that, from an anesthesia perspective. That being said, anesthesia is obviously invaluable, and a lot of times they'll tell me if a patient is too sick for the operation that I'm planning. So I really, really depend on them and rely on them. So there's a huge component of teamwork, and anesthesia plays a huge role.
Appreciate it again, Dr. Mahmoud. Sahil, Shadi, if you have any thoughts, please feel free to chime in.
I actually, for a time, considered anesthesia, but quickly realized, like during the rotation, that you just kind of keep looking over the drapes, because I just felt more interested on what was going on the other side. And I think the continuity aspect of it is actually huge. Like that's something, similar to like ER, the specialty of being an emergency physician, right? Like you see your patients, you take care of them, you do the job that you need to do, and then they kind of disappear, or you never follow up with them again. And that was a big thing that I realized I appreciated about the surgery aspect of it, right? That you can follow up and see what happens. So that was a big thing that kind of pushed me away from that.
Absolutely. Thank you, Sahil. And another question we have, and I think insight from each of our panelists will be interesting. How many publications should students aim to write each year? And do residency programs only count the publications that you have in the specialty that you're applying into? And I'm sure this varies greatly by each specialty, so I'd love to hear each of your thoughts.
I don't think that it has to be in the specialty that you're applying to, and you shouldn't be chasing after a golden number. I think personally, after sitting on residency review committees, we looked for people that had genuine interest in doing the research project that they had listed, and if they had true, like knowledge, like passionate knowledge about that research, and they'd be able to have a discussion about it. If it was just something that they listed just to list, and it was clear that they didn't really have a big role in that publication, it was very obvious. That being said, if you look at the statistics, if you're applying to neurosurgery, if you're applying to radiation oncology or whatever, they look more heavily at those things, and more of the successful candidates will have PhD degrees, and more will be AOA inducted or whatever. But I don't think you should be trying to target a specific number. Just go out and find something that is of interest to you and try your best to be involved in a research project, something that you can talk intelligently about to somebody. And again, I don't think it has to be in that specialty. It does help, obviously, if it's part of that. It helps in discussion. They'll know what you're talking about. They'll be able to have a more colorful conversation with you. But if I had a colleague that applied to cardiothoracic, and he did like gender studies or women's studies or something in college, and he found that actually that was what most people talked about during his residency interviews, just because it was a little bit different and it was unique, and it was something that he was passionate about.
And then just one more point. Yeah, there's no like magic number. Obviously, the more publication that you have, it's just going to look better. The other big thing that research helps with is inevitably you kind of do a longitudinal project where you have to work with an attending. And I think that's part of the value from it, and that one, you have like a mentor that you can reach out to. Two, you have someone who can comment on your character, your skills, your knowledge base outside of the clinic, outside of the the preclinical setting, and that ends up leading to a more robust letter of recommendation down the line. So I think that's part of where research kind of comes in handy as well.
And Shadi, do you have any thoughts maybe from sorry, go on, please.
Oh yeah, thanks. Yeah, I totally agree. You should just do what you are genuinely interested in, because you owe it to yourself to actually do things you're interested in. You're a super busy medical student, and there are going to be some things that excite you and some things that present themselves like they're opportunities, but might just be another time suck for you of doing, 500 chart reviews for this thing you don't really care about. So do what actually interests you, because one, you deserve to use your time in a good way, and two, that's the thing that you can talk about during an interview and people can tell you were actually engaged in it and you didn't just do it to, collect your numbers basically. I had a research year during medical school and I love that experience. I know that it's becoming more common because of shifting, things in residency applications, but I thought it was a great experience. So I can't say enough how much I thought that was valuable.
Phenomenal. And I think another question that we have is, do any of you do anything mentally or physically to prepare for staying in the OR for long hours?
No, OR is, I think, a little bit more flexible than people give credit to. Like if you really had to go to the bathroom, you could do that. You could pause everything, and as an attending, you can leave and come back 5 minutes later, or you can get a bite to eat. It's not like you have to stay there the whole time. Mentally, yeah, you think about the procedure. You think about where you're going to make the incision. You're going to think about how you're going to expose the anatomy, what you're going to do once you get there. If you're doing some kind of reconstruction, you have to be prepared on how you're going to do that reconstruction. If I'm planning to do a venous bypass, then I have to have the leg exposed so I can get vein if I need to. And if not, then I'll, need to make sure that the OR has the prosthetic grafts available to use. When you're doing endovascular work, you need to be aware of what kind of wires and catheters your cath lab has available to use. The other big thing about the OR is you have to have a team that's competent. You can't do big complicated cases with an incompetent assistant or a scrub tech that's very new. You're not going to want to do anything complicated like a carotid artery surgery or anything like that with somebody that's fresh out of training and it's their first case. So there's a lot of mental preparation that you have to do before you go into the OR. The fact that it's a long surgery versus a short surgery, I think matters less than whether it's a complicated surgery or a complex surgery versus a simple surgery. If you're just removing a lipoma or something like that, I'm sure you don't need to do as much mental preparation. But even something as simple as a lipoma, you have to have some thought before you go into the operating room, and that's why it's so important to meet your patient beforehand so that you know where you're going to be making your incision, and you have an opportunity to discuss with them their expectations after the surgery.
Absolutely. I think another common question that people have on a little bit of a different track. So how do grades, perhaps in the first 2 years of medical school, I think like some medical schools do quintile, some do ranking. One person was asking perhaps the medical school does a GPA. How do preclinical grades and clinical grades matter in medical school for residency? And on that same note, with stepping past Phil, how do you think that dynamic? If you have any thoughts, please feel free to share.
Speaking from the perspective of sitting on a residency review committee, we knew if somebody was AOA, but if they were, lower than that, we only had a very vague idea of whether they were in the top half or the bottom half. And to be honest, it didn't really matter that much unless they were AOA. They got some more points, but more than that was their ability to communicate. And the most important thing was something that we called the 2 a.m. test, which was, do I see myself in the middle of the night getting a phone call from this interviewee at 2 a.m, and would I be able to listen to them, and can they tell me about a patient, and can I get that message across whether they're critical or not critical? That was like a 2 a.m. test, and it didn't matter which quintile you were in at that point. So I would say that it does matter getting your foot into the door for certain programs, but once you're getting that interview, it doesn't matter as much. That's what I would say. And you shouldn't count yourself out of any specialty based on your class rank, I think.
Yeah, Sahil, Shadi, feel free to chime in if you have any thoughts or any comments maybe on step pass fail or preclinical or clinical grades, things like that.
This past interview cycle, we actually, as residents, got to sit on like the panel, and we had our own kind of interview room, and so we got kind of an inside look. And the step one being pass fail, like just meant that we were looking at step two to get a assessment of where patients lie, because more like there are schools who, let's say someone is not AOA, because AOA is a kind of good marker, and like Dr. Mahmood was saying, they can get like extra points or whatever. But in someone who's not AOA, and in someone who comes from a school that does like pass fail clinical grading as well, for example, or the quintiles or something like that, like you end up still relying on the numbers, unfortunately, but the importance of those numbers are to get your foot in the door, like he was saying. Like once someone is in front of you interviewing, honestly, like a lot of that other stuff doesn't even like go into the consideration when they do like the ultimate ranking. So it's important insofar as it gets you acknowledged, and it gets your application kind of lets it rise to the top of the pile.
This is entirely unrelated. My medical school didn't have grades, so I really can't comment on this, but the interview process is actually a really good time to network as well. I totally agree. Once you have your foot in the door, all's fair. It's just a blank canvas for everybody. But during the interview process, I found that I actually made a lot of connections. My field was really small, so that was more intuitive. But just know that wherever you're going, you're making an impression within your small field.
Absolutely. Okay, I think for the last two questions in the night, inshallah, if there was one thing you would do differently as a medical student to be successful into matching, what would that be? And I think we touched on this several times in the last hour, but if there's anything else, maybe thoughts on how to do things better, please feel free to comment.
Well, I am fortunate that I found a job that I really enjoy, a practice setting that I really like. If I found myself in a practice setting that was not like this, then I would have some regret, and the regret would be I just didn't go out and talk to enough people. So, that's more a topic that you'll deal with during residency when you're applying for a job. Is you need to be able to interview in as many places as possible and really look at the nitty-gritty details and look at what the differences are in practice settings and exactly what you're going to be getting yourself into. And I guess part of that is, as a medical student, when you're applying for residency, you're going to want to know exactly what that entails. So obviously go out and experience as much as you can, talk to as many people as you can. As a surgeon, most of the time, most of what I do during the day is actually talking to people. I'm just constantly talking. At the end of the day, I'm just like tired from talking because I'm telling patients what their expectations are. I'm like pre-oping them. I'm explaining to them what the surgery involves. If there's any complication, I have to explain to them why it happened or how I'm going to fix it. If there's a consultant that sends me a patient, after I see that patient, I'm going to talk to that consultant, give them feedback, tell them what's going on, what my plan is. I'm always directing staff in the OR what to do, what equipment to get. If there's any medical students, I'm lecturing them, telling them what we're doing currently, what the topic is about. And then there's different meetings that you have, like AMMSA and administrative meetings to talk about what devices you want to get approved for the OR. So a lot of what you're doing is communicating. So if you want to go into a surgical specialty, you have to get used to putting yourself out there, being confident, being comfortable, talking about this field, and you really got to be aggressive. You can't be you can't sit on the sidelines. This is not a passive field, is what I would say. If you're again, not everybody is meant for that. Some people like that passive environment. You can go into pathology, you can go into radiology, you can go into a lot of different fields. But surgery, you're going to be front and center. You're going to be talking to people all day. So be aggressive, learn from people, get feedback.
Okay, so and then last quick question to sort of wrap up the night. Any thoughts on personal skills or hobbies that helped you developing surgical skills or in general for your careers or matching or residency?
I used to guitar. So that I think playing video games and that sort of hand-eye coordination helped with all the laparoscopic skills that I did during a general surgery. Of course, now I do zero laparoscopic surgery, so all of that has gone to waste. So, you're not going to know exactly what you're going to be doing as an adult. So just do what you find is fun, and if you're interested in something like laparoscopic surgery or any type of surgery, microscopic surgery, do something with hand-eye coordination. Learn how to play a violin or a guitar or a piano. But yeah, just like Shadi said, you have very limited time as a medical student, so don't waste time on things that you don't truly enjoy. Find something that you're passionate about. Find something that you can just turn your mind off and do for fun every once in a while, because medicine can get a little bit lonely, because with your family, they're not going to understand your hours. They're not going to understand the stresses of your life. So it's something that you need to have some hobbies where you can just kind of go off on your own and enjoy it on your own time.
And just a very small, agree with everything. Just to further that point, doing something that you're actually enjoying will make it that much easier to kind of talk about it if it comes up during interviews. Because if you're again, going back to the idea of so much of the application is how you interview. And if you talk about things that are outside of medicine and you show them that you're kind of a human, people appreciate that a lot. But that kind of means that you have to be enjoying or living outside of the clinical realm as well.
One final thing I want to add too, I totally agree with everyone. And I don't want to take us too long, but I think it's really important to reflect on what you genuinely enjoy and use that as your inner compass, because I find that the people who are burnt out or unsatisfied with their careers often ended up in their positions because they were living somebody else's dream or doing something they thought other people wanted of them. And you've come way too far in school and everything to just do whatever you think other people want of you. So I would say definitely seriously self-reflect of what you actually like across your rotations and follow your own curiosity across all domains, all the topics we've talked about, research, mentors. You'll always have some sort of hunch inside of you saying, hey, I thought this was kind of cool. And that little voice is what you should listen to, because that's what will keep you joyful and happy, I think, in your career.
Jazakumullah khairan, everyone, for coming. I really appreciate, especially our panelists, for all the great insights and especially the closing thoughts. With that, I do want to just plug AMMSA for a quick second. If anyone is interested in starting a chapter, we've been rapidly expanding as well. You can reach out to us at outreach@ammsa.national.com. So we're more than happy to help anyone out by email. We'll send up follow-up emails as well. And Jazakumullah khairan, everyone. And with that, we can answer the last. Bismillahirrahmanirrahim. إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. Jazakumullah khairan, everyone. Hope you have a good night. A special
Thank you.
thanks
Thank
to
you for
John.
inviting me.
Assalamu alaikum.